Welcome to Discovering Africa Through Technology, the podcast series that showcases the brilliance of Africa's great minds, innovators, and experts as they tackle complex challenges with homegrown solutions driven by knowledge, technology, and innovation. Our podcast is inspired by the African Union Agenda 2063 Aspiration 7, which seeks to rebrand Africa and change negative narratives and perspectives through science, technology, and innovation. We believe that Africa has the power to solve its own development challenges and become a strong, united, resilient, peaceful, and influential global player and partner. Join us as we explore the transformative potential of technology in Africa with your host, Razia Kulatain Mwanga, and learn from the experts driving change on the African continent.
Welcome, and in this episode, we shall be talking about Breathe Easy, how technology and artificial intelligence are transforming lung cancer care in Kenya. How technology and artificial intelligence are being harnessed to fight cancer in low and middle income countries, with a spotlight in Kenya, with Dr. Elias Melly, the CEO of the National Cancer Institute of Kenya. Dr. Elias will share inspiring examples of African-led innovations, from artificial intelligence-powered screening tools to telehealth services that make early detection, which is very important in cancer, and quality care more accessible. In our discussion, we shall highlight practical technology solutions, including mobile screening units, smart diagnostics, and digital data, how they fit into the broader public health strategies to improve cancer outcomes, proven research and innovation facts of hope and accessibility, existing scalable innovations that save lives and advance health equity. So to start us off, welcome Dr. Elias Melly. Most of us know you and have heard about amazing things that you are doing in Kenya in terms of cancer, especially on lung cancer. Start us off by telling us about yourself and the amazing work you are doing, and who Dr. Elias Melly, the CEO of the National Cancer Institute of Kenya, is and what you are doing. Welcome.
Great. Thank you, Razia. Really honored to speak to you about the amazing work that we are doing here in Kenya. I am the CEO of the National Cancer Institute of Kenya, which is an agency under Ministry of Health that was established specifically to address the rising burden of cancer. And lung cancer is one of the many cancers that are a real challenge in our country. A practicing physician, clinical oncologist. I do both medical and radiation oncology in public health hospitals, primarily Moi Teaching and Referral Hospital, which serves the western part of the country. And passionately, patient services is at the heart of my work, because that is where the rubber meets the road. I am also an adjunct faculty member at Moi University School of Medicine, Pharmacology, and Toxicology Department due to my research interest in cancer therapeutics. Also provide mentorship at the clinical areas in oncology space within the hospital. I am also privileged to sit in this policy position at the Ministry of Health, to be able to develop policies and implement these policies and give feedback as well on the initiatives that seeks to address the burden of cancer across the entire continuum of care. Conduct research within the National Cancer Institute, as well as with the Ampath Oncology Institute, which is a consortium of Moi Teaching and Referral Hospital, Moi University, and a couple of Northern America and European academic centers, which have a lot of interest in cancer care in Kenya. It's good also to mention my role in advocacy. I am a good friend of survivors or thrivers, patients who successfully won the battle against cancer would refer me to, because I am really passionate in supporting our patients to have better patient experience. Patient navigation is also at the heart of my work, to make sure truly give our patients a better experience as they navigate through their cancer care, from community initiatives to hospitals, and also reintegrating them back into the normal life within their communities. So happy to be part of you today.
Wow, thank you so much for highlighting some of the key things that you are doing. Could you tell us a little bit more about what is the current situation of lung cancer in Kenya in relation to what is happening in the continent and in the world? What are the statistics saying?
Yeah, so thank you. It is obvious that the burden of cancer is rising, amongst all countries globally. The difference is how do we address the rising burden of cancer? And to be very specific about Kenya, before I speak to lung cancer cases, allow me to talk about the overall burden of cancer in Kenya. Every year, we do diagnose more than 44,000 new cases, and more than 32,000 cases die from cancer every year. Lung cancer is among the top 10. Talking about top 10 is anecdotally an underreporting, because I do believe that there are so many lung cancer cases that unfortunately we miss, and therefore it could potentially, in due course, as we streamline our healthcare system in cancer care, probably might even rise to top 5 cancer in the country. Among the lung cancer cases, we do diagnose them when it's advanced at stage 3, stage 4, and unfortunately, more than 92% of them die from this same disease that they are diagnosed with. So mortalities are very high, morbidities are very high, outcomes are very dismal, less than 5% survival amongst patients diagnosed with lung cancer. It is imperative that we are discussing today how we can leverage on existing research and development, technology-powered tools to make sure we change the statistics to something that is favorable. This is typical presentation amongst all African countries. But if you compare this now with the global landscape, in high-income countries, the outcomes of lung cancer are much, much better because of targeted interventions, beginning from awareness to early detection, proper diagnostics, through precision oncology, where we have leveraged on technology to profile these patients to specific biomarker targets that would then have very specific therapeutics that would fortunately treat these patients with better outcomes and very minimal side effects. I hope that as we continue with our efforts, we should be able to have better outcomes of patients with lung cancer, just like high-income countries where the burden is high, but also, the interventions are working. Patients have been treated as high as more than 70% survival over 5 years.
That is alarming, because I was looking at the statistics where you say that at least 44,000 new cases every year. Most of these people come late for treatment. I was talking to a surgical oncologist from Tanzania, and the thing that he raised most was that most of these cancers would have been treated, but the problem is that these people went late. Limited testing also, that was another problem, because when you think about lung cancer, it is not easy to detect it compared to other cancers like skin cancer, like breast cancer. Tell us in terms of what the country is doing.
It's a reality that the lung being an organ which is intrathoracic, we may not be able to have access to it as much as the skin, breast, if we were to leverage on existing screening or early detection signs. It is a reality that most of our patients present with advanced disease, the challenge of awareness, and for the longest time, lack of screening modalities for lung cancer. What is interesting, Rosia, about the lung cancer disease in our country, unlike Middle East and Europe and the US, where risk factors include smoking, in Kenya and probably sub-Saharan Africa has a different disease at the biological level. History taking at the clinic, most of my patients, more than 90% of my patients with lung cancer are non-smokers. Most of these patients who do not have non-small cell lung cancer, which is squamous, they have non-squamous. What does that mean? They have a different biology of the disease completely. It's non-smoke related. Probably secondary smoking, maybe, but less smokers in our setting compared to other countries. Our country is still very intentional to make sure that if there are tools that have been discovered and validated and approved by World Health Organization and they've been found to work in other settings, then through implementation science, we are able to deploy these initiatives in the community. The reality is, for us to do stage shifting, to move from stage 3, stage 4, we have to focus a lot on health promotion, create a lot of awareness through information, education, and communication. And our government has a robust, just rolled out universal health coverage. And all the cancer initiatives are anchored as well in the community. We have community health promoters who are based in the community. They are opinion leaders who have been equipped with information on what to share to the community about addressing, risk factors for cancer in general, risk factors for lung cancer, colorectal cancer, breast cancer. And therefore, they continuously inform the community. So that is one strategy that our country is using to make sure that we educate the community. And we are also using mainstream media to educate the community on avoid smoking, potential chemicals that have been associated with lung cancer, available screening modalities for cancers in general that are screenable. And lung cancer is one of those conditions now on this. Previously, we have been screening our patients for lung health in general, because there are many other conditions that affect the lung. And cancer focus is bigger than ever. Previously, our focus was mainly on infections, pulmonary, tuberculosis, asthma, some chronic lung diseases. But now, because of the rising burden of cancer, there is more focus on cancer. And to improve the possible diagnosis of cancer, recently our government deployed more than 80 AI-powered high-resolution X-rays to our community hospitals. This is one of the biggest milestones ever achieved in our country to address early diagnosis for lung cancer. And I've been part of previously an initiative supported by Cure AI and AstraZeneca, where we were able to use AI to compare the findings of an X-ray powered by AI versus findings from a CT scan. And we had an algorithm, and actually leveraging on AI, we are likely to increase detection of lung nodules that are likely to be cancer. I'm quite optimistic that this is going to address our major challenge. We, of course, are yet to roll out, low dose CT scans for the community, unless those patients who are high risk with family history of lung cancer or heavy smoking, those are patients that we are actually advising on low dose CT scans. But for the general population, the opportunity to have community-based screening using AI-powered X-rays is going to be a game changer in early detection for cancer, because the healthcare system also will not be burdened when we diagnose these patients early, because interventions to treat these patients is going to be less costly, and also the interventions will have less morbidity, and the productivity from these patients will also be quite high. So we are really, really excited that we are addressing the burden of making sure that we inform the public and roll out, a countrywide sensitization on screening. And now this is integrated in our TB clinics, because patients who are diagnosed with TB get regular X-rays. And we realized, as we take history from our patients, more than 95% of our patients who have lung cancer would have been treated for TB, for the last 6 months. And this is unfortunately one of the reasons why our patients may present early to the hospital. But unfortunately, we treat them for other things. We miss the diagnosis completely, and the disease progresses. So we are quite excited that we have captured this, including the recent rollout from a policy perspective of our integrated lung health initiative, or policy framework that now guides on how do we address lung health in general. We are screening people that have not presented with any symptoms. So anybody who presents with any challenge, we assume there's a lung problem, and cancer could be one of them. It could be one of the differentials. We've also capacitated most of our healthcare workers. Razia, it's not common sense that if you've gone through medical school or medical training that everybody knows about lung health and about lung cancer to be specific. So there has to be continuous professional development, working with our partners in the health space, within the government and without. We've been able to do continuous capacity building across the entire team, both clinical and non-clinical, and also those who are in the oncology space and those who are not. Because cancer can only be taken care of by oncologists like myself once a diagnosis has been made, but most of these challenges would be faced by primary healthcare physicians who the patients get into contact before they get into the specialist. So there's a lot of discussion and a lot of continuous education in that space.
Most of these people who are being diagnosed with cancer, lung cancer, are non-smokers. So maybe you are thinking maybe secondary smoking. Out of curiosity, what is the reason for having these people who do not smoke and are probably not even secondary smokers having more lung cancer? What are the reasons behind this?
Good question. There is an opportunity there to find out why the disparities. And certainly it has everything to do with our genetic makeup. What is the exact proto-oncogene or oncogene or a tumor suppressor gene? It is what is work in progress in research. This week, we just had a meeting with some of our partner institutions through a research program called SAMBAI between our Kenyan Ministry of Health stakeholders and Morehouse School of Medicine in Atlanta, as well as John Hopkins. And we were discussing on how to look at environmental factors, to look at genetic factors, to look at social factors, and biological factors as well as documentation of why we have cancer disparities from a diagnostic perspective before we even address the challenges with cancer disparities in issues related to equity and inclusivity. But we appreciate that genetically we are different, between the Arabs, the Caucasians, Asians, and all the races globally. But at the same time, even the Asians who probably have lived in Kenya might have a different genetic makeup compared to the Asians who've lived in Korea or India. The Americans who have lived in Kenya might be different from the Americans who have lived in the US. So there is also a component of epigenetics that where you grow up, where you're brought up, the environment also influences on your genetic makeup. We are yet to get to the nitty-gritties, and this research that we are involved currently, we are quite optimistic and looking forward. It might unlock some of the important questions that we have to address our disparities. Probably it might even be an opportunity to establish, an African genome atlas. What exists currently is what was developed through a study that established human genome through a project that was funded by an American institution. But if you look at whatever biomarkers were looked at, it is not representative of the entire globe. So there is an opportunity right now for the sake of representation to make sure that every human being that lives in every continent in this world should contribute into these clinical trials that would certainly give us answers which are different. And the environment will play a very big role, and our genetic makeup at the molecular level will also play a very important role. Scratching the surface on why we are, very keen on this study. It's a huge project. It's a project that will take time. And Razia, unfortunately, with cancer, it's not like infections where a clinical trial can answer your questions within a year or two, because appreciating oncogenesis, this is how cancer develops. It is a process, to cause any damage to the DNA. It is a process that can go, years before cancer causation occurs. And therefore, we are hoping in the next couple of years we should be able to answer these very specific questions to lung cancer and also to other cancers that are a real challenge in our continent.
Talked about the role of technology, and you've talked about AI-powered scans that do more compared to normal scans. Can you tell us about other innovations or any other tools that you are using for early detection, and how is that working?
Great. In general, we are having a lot of community engagements. Even as we speak right now, I have my team which is in the community, because that's where it begins and that's where it ends. A lot of the work they are doing is engaging the community through an integrated screening program. Very costly to screen, to educate the public and also screen for one specific cancer all the time. So when we are talking about cancer screening, the information is all cancers that we have data about, what are their risk factors, so that we create awareness on all of them where possible. And when we talk about screening, we want to make sure under one roof we are screening for women for cervical, breast cancer, organ-specific cancers that are common in both men and women. We make sure they are also integrated in this screening, colorectal, lung cancer. It is really yielding results because I've been part of a recent community-based study. After engaging the community, we have seen better outcomes based on early detection. And this is a result of engaging the community through mobile clinics. So I can confidently confirm that this is an initiative that should be sustained. This is an initiative that should be supported and heavily financed so that we're able to diagnose these cancers early. It's also important to mention that linkages to care after diagnosis is very important. While in the community, we also do patients triaging to know which patient will benefit from care within the community and which one should be referred to an advanced center for possible additional investigations, whether it's additional radiology and imaging, as well as additional surgically if we need any specimen to be collected, whether it's through open surgery or through minimally invasive surgery or through interventional radiology initiatives to make sure that we're able to collect sample and analyze it. And at this time, it's also important to mention that previously, due to shortages of staff and also lack of experience in some of staff, and the fact that we have very minimal, heavily trained workforce, we have an opportunity now that is growing to leverage on AI in diagnostics as well. We've had diagnosis or overdiagnosis or underdiagnosis as well based on the different quality aspects in a trained healthcare worker or quality-related challenges from the machines that we are using as a result of probably maintenance of these machines, and also the processes of handling the specimen. Sometimes these are challenges, but AI is now, streamlining that because based on big data, we are able to now digitally be able to examine images, if it is radiology and imaging, or also cut the sections and take images from pathology specimen and be able to be subjected to AI reporting. We've one very advanced laboratory in country currently that is able to look at the specimens powered by AI, the pathology sections, and be able to improve on accuracy of diagnosis. In cancer care, Razia, unfortunately, if we make the wrong diagnosis, then downstream we are going to be misled in any therapeutic options that we have. So I am a big champion of quality at all levels, from the community through the entire continuum of care. And it's important, therefore, that through our medical training, just like HIV 3 decades ago was a topic that was being discussed in every training program, including high schools, elementary schools. That cancer discussion now, the bit of training is now taking shape, and it is now integrated in curriculums to make sure the output of the healthcare workers has sensitization on cancer. We did that for HIV and we succeeded. So we're not going to reinvent the wheel. There is a path others have worked down that road and it's been successful. So I'm very certain that with the initiatives that we have in cancer care, we should be successful and change the narrative in the next couple of years.
You've talked about the role of technology, and you've also talked about limited manpower, limited resources, although there's increased knowledge, and you're talking about integrated one-place screening. There are opportunities and challenges. How has artificial intelligence helped in diagnosis of cancer where you have a shortage of manpower? How has this helped you to bridge that gap, and how is it working?
Our country is among the leading countries in technology innovation, and we always want to reference one innovation that Kenya is known for, which is mobile money transfer called M-Pesa, technology that many other countries now are adopting it. Therefore, we are very keen, leveraging on existing opportunities in technology. Our country leadership has emphasized through the president himself and all the structures to make sure that technology is entrenched in all our activities, both administrative and technical. Therefore, where we have limited human resources, we have used technology, to bridge the gap, because all that we need to do is transition now our old equipment that we had. In some centers, it has transitioned. In others, it hasn't. We still rely on a pathologist looking at the images because lack of infrastructure to support AI-powered or technology, telehealth, telepathology programs, because there's also infrastructure that is required in that. And also availability of energy, power, because all this equipment requires powering. So we have in some centers now leveraged on telepathology by taking images of sections of pathology specimen, and where we don't have a pathologist in post, we are now, first of all, sending this to be reported remotely. So that's an opportunity that we are using technology. But most importantly, for us to address now the diagnosis bit, we are subjecting now these images to be reported by AI. And I think that's one of the greatest breakthroughs that is helping us address the gaps that we have. It is not enough to just have a pathologist. We also need to have an experienced pathologist. We need to have a pathologist who, when they look at specimen, they are able to say, I can see changes in the cells that helps me conclude that this is squamous cell or this is an adeno, carcinoma and not squamous cell carcinoma. Now, leveraging on big data, we are able to get much better diagnostics, much better, accurate diagnosis. First of all, confirm it's cancer. Two, what would respond best? Is it going to be surgery? Is it going to be radiotherapy? Is it going to be systemic treatment? And with additional investigations, we would be able to know whether is this a cancer that would respond to a particular targeted therapy, whether it's immunotherapy or whether it is, TKIs. I would want to appreciate that opportunity that has been offered to us through AI in telepathology. And that space also is quickly moving into teleradiology as well, where we are able to subject our CAT scan images, or whether it's PET scan images, be able to get a report generated by AI and be able to compare the same report, by our radiologists, which is as a human face, and the other one is technology face. And now we are finding them as comparable. We've even moved now beyond even diagnosis, and currently radiotherapy planning. We are moving into that space where now radiotherapy planning is AI powered. So it's not going to be the manual, I do radiation oncology. So when we are contouring the lung, if the disease is in the left lung and we want to protect the right lung, we are using technology and it just contours the organs at risk, and we are able to modify probably the volume, the treatment volumes, where we want to focus on treatment, but minimal modification, because AI will have done a lot of this. So quite grateful that our government, our country is, integrating this, and some are in private sector, more in private sector, a little bit in public sector, but the intention really is roll out this in all our public institutions, because this is where most of our patients receive care.
Cancer is a very expensive disease to have, and only the rich can afford. Talk about chemotherapy, radiotherapy, apart from just being time bound, also resources. This program is about promoting the best of African innovation technology. Can you tell us about some outstanding, proven, promising tech solutions that exist in Kenya and probably in Africa to try and solve this problem of curing cancer, treating cancer, early detection that we can celebrate and other people can learn about? Also, tell us about some interesting research findings that have been done in these particular areas that can help solve this cancer problem.
Based on, financially or economically viable innovation, it is going to be affordable, cheap, reasonably possible to spend very little in cancer treatment if we focus on prevention and early detection. The reality is, where there is limited resources, especially in Africa, our best luck would be on focusing on community health, on focusing on early detection. That is where we are putting all our dollars. That's where we are putting all our resources. And allow me to share how Kenya will be leading the world in providing financial protection for patients who are diagnosed with cancer through our recently launched social health care financing in our country. We recently had reforms towards rollout of universal health coverage, and one of it was establishment of social health authority, which is the premier institution that is going to finance healthcare both in public and private sector, where part of it we are going to roll out community initiatives that are paid for by the taxpayers' money. And this is to enhance early detection and early diagnosis. And while in the community, the tools that we use are technology powered. These are tech discoveries that are going to be game changers, while clinics, telehealth, that enables, very deeply rural Kenya that most healthcare workers are not found, to still access care and make sure there is no inequities, because if you are in rural Kenya and you are leveraging on technology, you'll get similar care as you would if you are in Nairobi, which is the capital. And that is one way of making sure that technology assists in reducing the financial burden to families when they don't get screened and they unfortunately get diagnosed with stage 3, stage 4 non-curable cancers. Our financing mechanism in our country, for those who are diagnosed, most patients could not afford cancer diagnosis, but now we have an oncology benefits package that is able to pay for diagnostics, both pathology and radiology, that is also going to pay for treatment, whether it's surgery, whether it's chemo, whether it's radiation. And these are resources which are pooled. Our government is very intentional, and they are very intentional in cancer care, to be very specific. It's a model that if it works out for cancer care, then it will work out in everything else, because cancer care is pretty structured, in terms of diagnostics and in terms of targets that we need to offer. In terms of, and these are, initiatives rolled out based on research that has been conducted within our institution, operational research, to just demonstrate why we should invest in primary healthcare, why we should invest in prevention. We know very well that if you invest, $1 in prevention, you are going to save $16 in treatment, and you are going to save even more dollars if you invest in better diagnostics, in treatment. If you look at the recent World Health Declaration on proof diagnostics, there is room to make sure we are able to treat our patients when diagnosed early, because there is going to be financial protection. We are also involved in laboratory-based research. Working with our partners, we have now better molecular diagnostics for lung cancer. Previously, we could not even discover specific targets as basic as immunohistochemistry. You know, for lung cancer to be very specific, we could not be able to identify whether these patients have cytokeratin positive or whether they have TTF1 positivity. That would then confirm that we are dealing with the non-squamous lung cancer. At the same time, we were not even able to go further and to do molecular diagnostics. Right now, almost all of our patients with cancer are able to get EGFR, diagnosis, and this is working in partnership with our partners institutions like AstraZeneca. We are now, through immunohistochemistry, are able to also diagnose, PD-L1 or PD-1 targets for possible immunotherapy for our lung cancer patients. This is work that are being done within our lab with a research mind to discover how does a Kenyan patient diagnosed with lung cancer behave. And we've been able to publish our initial data on the burden and the outcomes of lung cancer, specifically through an MLCCP program that I was part of the western part of the country. The National Cancer Registries, very important. These are infrastructures that we would really want to use for national planning. At the same time, cancer registries are going to help in documenting what happens in the population, because at the end of the day, population health matters. And this also infrastructure for research. We will be able to discover ourselves when we have not only the general population-based cancer registries, but also disease-specific registries. So we look forward to having a comprehensive lung cancer registry that is going to inform who we are and how do we respond to different interventions.
What excites you about the future of technology and AI in cancer care in Africa? And how do you envision this innovation scaling up and impacting cancer prevention and treatment in the next decade?
Well, quite excited. Technology is revolutionary, and ignore technology at your own, peril. And we do appreciate that tech is not a standard magic, but tech is an enabler. Technology will improve on quality, will increase efficiency, cut down the costs of treatments. Technology will definitely improve outcomes by addressing these variables that I've mentioned, because that is the goal at the end of the day, that no one gets diagnosed with cancer. And equally, if unfortunately one is diagnosed with cancer, then there has to be better treatment, better interventions that will still assure them survival. I am quite excited that currently Africa is not just a recipient of technology, but we have a lot of innovation now locally generated that is also informing even other regions. I mentioned about M-Pesa. There is so much that is now happening in our region. We've been a consumer of data that is generated specific to what I would call foreign to Africa, because it is data that is generated by countries that have invested resources in research. And unfortunately, this would not exactly be a replica of the challenges that we have. We've now built more capacity for clinical trials in our setting. In Kenya, we are now participating in clinical trials, which we were not participating before. More companies are coming in to work with us to make sure that even as we address the burden, entrench technology, in 2027, Kenya here is going to host World Cancer Leaders Summit, which is hosted by Union for International Cancer Control, UICC. It's going to bring everybody here in Nairobi from the entire globe, including tech companies. And while they will be here, we will also be able to showcase what we've been able to develop locally. So it's quite exciting looking into the future. By investing in science, technology, and collaboration, innovation, we are going to turn around these challenges into opportunities and even be able to make sure that this challenge is easier addressed than when technology was not part of the care that we are providing for our patients. With continued support, the technology will bring equitable cancer care within reach for all the Kenyans and all the Africans, turning today's challenges into opportunities and also save countless lives that currently are at risk of being affected by cancer. And when we talk about these statistics, we are talking about lives. We are talking about families. Someone's parent. We are talking about someone's daughter, son. We are not just talking about numbers. There is a lot of emotions around those statistics. It's always my wish and my vision, but in the long run, while we put in place mechanisms for early detection and prevention, the graph should go down significantly in lung cancer as well as all the other cancers. I have a vision that one day, one time, we shall have a world free of cancer. Thank you very much.
Thank you very much, Dr. Elias Melly, CEO of the National Cancer Institute of Kenya, for your valuable insights. Having this conversation with you has really given me a broader understanding. I know cancer is an expensive disease. Not many people can afford it, can survive with it. But then you've given us insights on how technology can provide equitable treatment and opportunity for all survivors, with money or without money. And also, I love the idea that you brought up, that community engagement and awareness is very important. But also, I love the integrated one-place screening, because you find that most of the cancers that get screened are the ones that are probably more prominent. But with this screening for all cancers together, it gives people more opportunity. So thank you very much for your time. Until next time, this has been your host, Razia Kulaten Mwawanga.